the sensation is arrived in the cerebral cortex. Now the issue is how it is processed. To brief, the area located in the parietal cortex posterior to the central sulcus, where the sensory mode, the somatosensory, the posterior sensations, posterior column sensations are relayed. This area, post central sulcus area, is known as a primary sensory area, or S1, or areas 3, 1, 2. Already I have described. The representation of various parts is shown in the homunculus and is proportionately greater area is allocated according to the functional significance or functional importance. I have already mentioned about it. The thalamo, because the cortex is having 6 layers, that I will be dealing separately on cortical these things. They have 6 layers. Layer 4 is a layer which receives sensory input, and the thalamocortical projections relay on the layer 4 of the primary sensory cortex. And from these layer 4, maybe when we study in detail, you will know how it communicates with the layer 2 and the layer 3 and the layer 5. Each one of them, it gives a dendritic carbonizations to the, because this layer 4 is inner area, then there are 3 superior layers of which it gives a dendritic carbonizations. So then there are axon collaterals in the layer 5, that is the pyramidal cell layer, and the 6th physiomotor cell layer. So they are also all these things distributed. Already you have seen the localization of the sensory sensation is shown. Suppose if I place a microelectrode on the cerebral cortex or the parietal cortex and stimulate it, and the person during the neurosurgical operations, person feels the sensation of a particular modality it has received. So that means each of these receptors are localized, the sensations are also localized. It will tell that he has a touch, he has a brush, he has a vibration, or whatever he will tell all those things. The S1 area, that gives outputs to the somatosensory area 2, as well as it also gives output to somatosensory association area in the posterior parietal cortex as shown for further processing. Hence, the lesions of the primary sensory area lead to loss of appreciation of the external sensations. Also, the conscious proprioceptive sensations from the opposite half of the body, because they're crossing over in the medulla. So that means if there is any lesions here on the right cerebral sensory cortex, there will be loss in the left side of the body. What are the functions? Because if you are looking at in S1, there is a localization of the sensation. S1 receives the input. S1 try to understand the inputs in association with S2. The S2, that is secondary sensory area, is located just above the upper lip of the sylvian fissure or the lateral sulcus, that I have already shown. The representation of the S1 or S2 is face area is located most anteriorly and the leg area is most posteriorly. In studies, it has been shown that S2 S2 alone cannot understand, if there are no inputs from S1, will not process any sensory modality. So that means it requires the input from S1, and then it refines or it gives attributes, further attributes of the sensation. That means it acts as a helper to S1. So here in S2, it is represented bilaterally on both sides of the cerebral cortex. The output from S2 will go to posterior parietal area, that is the somatosensory association area 5 and 7. Also, the S2 will communicate to the limbic association area, especially the hippocampus. Now these two association areas, one the somatosensory association area and the limbic association area, they put them together, they give several attributes of the sensory modality. S2 basically concerned with the tactile discrimination, the spatial location of the receptors, and other information of objects stored in the memory, because recall memory, because it is connected to the limbic association area, it will try to bring in that. Say for example, a touch. Other class I was talking about a touch of a mother. That means that memory is stored. In the memory it is stored, this is the type of touch. So then that type information is brought through the hippocampus here to the S2 and gives attributes for that. So in the middle of the night somebody comes and touches you on your back without you seeing him, you suddenly get scared. So these are the type of sensations. So that is a stranger sensation that you can detect. Moving on, what are the functions of the posterior parietal area? The posterior parietal area is a somatosensory area, somatosensory association area. That means it associates all sensory modalities here. Both of them, they are getting associated. So this represents the area 5 and 7 of the Brodmann, categorized by the Brodmann. It is situated superior parietal lobe, posterior to S1. I have shown it. This area has a number of cluster of neurons which would understand shape, which would understand, which will be triggered by size, which will be triggered by the texture or roughness, and which will be triggered by the direction or orientation, or direction of motion or angulation, or many attributes of the touch, or the pressure, or the vibration. Other details of the objects, further other details of the objects in reference to other sensory moduli are analyzed and decoded. So that means this posterior parietal area gives the object a shape, gives the object a size, gives the object a roughness, what is the nature, and also how that felt, or how one that object is felt. So then it gives a, even it will try to know what is its weight. Say for example, blindly I am touching an object. Suppose if it is a book or whatever, then I will say, I will just have a rough approximate of that book size and this thing. Or even if I am just trying to pick up a more mobile telephone, and I will know that what is the, even if by touch I will say that what is the probable weight of the thing. So like that, these textures are analyzed with the association areas. Further, this association area communicates with the visual association area, communicates with the auditory association area, communicates with the limbic association area, Also with the motor association areas. So accordingly, by just touching, a imagery, visual imagery can be obtained, or the person will have a visual imagery of the object he has touched. Or he can imagine what happens if that, what type of sound that object may produce if it falls. That is an auditory association area. Also, suppose it's a knife. If it is a knife, object is a knife, then he can associate the knife with the emotion associated with the knife, whether it is harmful or not harmful, and what are the things. Here I'd like to give an example. Suppose if I touch something like a rope-like structure in the night, and it is soft and slimy, suddenly what is coming to your mind? The coming to your mind is a snake. Now, if that is a snake, then what are the emotional components associated with a snake? That means you get scared. You immediately throw it. Then you will just be restless. So that is the type of association, because a visual, auditory and limbic association areas try to give a meaning to the object. The somatosensory area gives the object properties, attributes of the object, and here they give meaning to the object. This area, therefore, the posterior parietal area is essential for what is called a stereognosis. That is the ability of an individual to recognize the objects placed in his or her hand when blinded. I have already explained this thing in the previous class. That means a commonly used objects like a pencil, pen, I can immediately recall and say that this is what it is. That is a stereognosis. To review here, association area gives the attributes. The association area in association with the other association areas gives a meaning and the existence of the individual. Now I am just showing the picture of the brain, where you see the primary somatic, what is it? That is the association area, that is the central sulcus there. So then in front of the central sulcus, anterior is the primary motor area and posterior is the primary somatic area. On the top of this thing, secondary somatic area. Here you have in the angle, just above the primary auditory area, you have S2 here, just above the primary area, that is the sylvian or the lateral sulcus, where it is ascending up. In that corner you have S2. So then we have the association area. This association area, that's only parietal association area, it's not enough. Parieto-occipito-temporal association area. This parieto-occipito-temporal association area combines the three modalities, that is a sensory modality, the visual modality and the auditory modality. All of them put together, they are sensed here. That is the association area. On this side you have the occipital cortex, that is a primary visual. On the other side you have the frontal cortex, that is the frontal association area. So then supplementary motor area and the premotor area are located, and you have this in the lower this thing lower part, that is a limbic association area where hippocampus and all the memory linked issues are there. Just to give you a brief idea about how the sensory modalities are going through. Now coming back, what are the various clinical abnormalities associated with this posterior column sensation? There is what is called a condition, subacute combined degeneration. The subacute combined degeneration is seen in pernicious anemia and nutritional vitamin B12 deficiency anemia. And in these, the vitamin B12 is necessary for the myelin synthesis. In pernicious anemia, there is a deficiency of the intrinsic factor which is necessary for the B12 absorption. Whether it is the deficiency of the intrinsic factor secreted from the stomach or because of the extrinsic factor, that is a nutritional vitamin B12, B12 is absent. If B12 is absent, there is no synthesis of myelin, because of B12 is also necessary for the normoblastic reaction in the hemopoiesis. In the erythropoiesis, B12 is necessary for normoblastic erythropoiesis. So in the absence of B12, there is a megaloblastic erythropoiesis. That is why you have the macrocytic anemia. The large cells are produced. That means erythropoiesis is not in a normal phase. But however, coming back, because the myelins are myelin synthesis is hampered, then the fibers the myelinated fibers are not being myelinated. They will lose their myelination, and hence you will have an abnormality. Most of the sensations carried by the posterior column are through the myelinated fibers. Since myelin is affected, so they will lose. Hence you may find the loss of sensation, the touch, vibration in vitamin B12 deficiency. This condition is called subacute combined degeneration. Maybe you will be studying this thing in clinical side in detail. Then comes a degenerating demyelinating disorders. So that means they will affect this myelination. And thirdly, I have just given an example of nowadays the syphilis do not exist because of the antibiotics. The previously in 1950s or earlier, before the discovery of the penicillin. So syphilis is going into secondary and tertiary stages. This is Tabes dorsalis is a tertiary stage of the syphilis, in which that would affect the large diameter sensory fibers. Hence, all these conditions affect the posterior column sensation. Because the pain and thermal sensations are carried by the unmyelinated fibers or thinly myelinated fibers, they preserve the pain and thermal sensations. That's one aspect. Another aspect I'm talking about, suppose you are sleeping. When you are sleeping, you have a habit of placing the hand underneath your head. Head is a hard object, and you may just sleep for hours together, maybe 6 to 8 hours you are sleeping, and when you wake up in the morning you are not able to move your hand, or you are not feeling any sensation in the hand. And this type of things are seen with the alcoholics, wherein they lose their after the intoxication, they lose their consciousness and they just sleep as they are, and this is known as a Saturday night paralysis. Saturday night means Saturday night boozing, and then going into a unconscious stage or a sleepful stage, and that type. This is one. The second, this is also called a crush paralysis. Crush means you are trying to take help of those walking aids in which the axilla you are placing it, and there is a pressure and that. So anything that pressure, that have a pressure on the nerve or a nerve trunk, that because of that there is a compression or external force that will stop the sensations. One important aspect, the large diameter fibers are sensitive to pressure, external pressure on the large diameter pressure. This thing they will stop conducting, whereas the small diameter fibers are not affected. Small diameter fibers are sensitive to local anesthetics. So the sensations carried by the large diameter fibers, that is, they are affected, that sensation is lost, and the posterior column sensations are through the large diameter fibers, that is A beta fibers, they are myelinated, hence there is a reversible loss of sensations carried by the posterior column. The vibration, touch, pressure is lost, even the proprioception, the position is also, he is not able to make it the position properly. So that is called Saturday night paralysis. Lesions of primary sensory area are difficult to produce because you have to produce a large area of destruction. But anyway, the fibers going, some of the fibers, they can be lost, but what is the result? You will lose the fine touch, vibration, and tactile discrimination and tactile localization on the opposite side of the body. These sensations are lost because of the lesions in the primary sensory area, and to produce that very large area of the sensory cortex to be involved. There is another term called astereognosis. This is the loss of stereognosis, or also it is known as a tactile agnosia or astereognosis. Inability to recognize or identify the common object by its feel. So it happens if you lose that somatosensory association area 5 and 7, and also anywhere in the path. If the S1 is not there, that is not reaching, you will have astereognosis. And you have, say for example, you have a tactile localization, but you have lost, you have a astereognosis. In that way, tactile is intact and the astereognosis is there, lack of the stereognosis, then there is a particular somatosensory area is affected. Like that you can identify. So you have a tactile localization but have an inability to have a discrimination. You can identify the type of lesion because discrimination is done by the S2. So that means these are particular areas may be involved. There is another condition, idiomotor apraxia. Again, this is the lesion produced in the superior parietal lobe, especially that somatosensory area 5 and 7. Loss of ability to produce purposeful skilled movements. I mentioned these association areas talk to each other. Association area, somatosensory association area talks to visual association area, talks to auditory association area, talk to limbic association area, talk to the motor association area. Here it is the loss of ability to produce purposeful skilled movement because the motor association is lost, that is not sending the information, and that will movements as a result of brain pathology, not caused by weakness or paralysis or lack of coordination or sensory loss. It's nothing to do with the motor cortex. It is something to do with the somatosensory area. You can identify like this. So now I've taken most of these things from the guidance textbook and the Genong's textbook. Please, you can refer them. In the next class or in the next lecture, we will continue with the proprioceptive sensations, pathway, processing, because today I did not cover about the proprioceptive sensation, and I will cover the proprioceptive sensations, pathway and processing. Thank you.